The guidelines have moved on. They have been published in 3 or 4 years ago, and it's a kind of a multi-point system, and if you have this number of points you're likely to have rheumatoid arthritis. But I like to keep it simple. If the patient presents with a new joint pain, it's symmetrical, and it's early morning primarily with a stiffness, that's likely an inflammatory arthritis. It may be a post-infection thing, or so-called reactive arthritis, and that can be treated with anti-inflammatories. But if it isn't behaving itself, if it's not responding to your straightforward treatment in 2 weeks at most, they should be referred for urgent assessment as to whether they have rheumatoid arthritis or not. Patients will present with their new stiffness. They'll want to know what's going on. They want a label on their arthritis, and we may not be able to give them that label initially. But one way of helping, or some ways of helping to establish a label, would be to check some blood tests, which would include your so-called rheumatoid screen, which would include ideally a rheumatoid factor, and also an anti-CCP, which is a much more specific blood test. I'm finding that not every hospital affords their local GP access to that test, but I think that that access is improving. That's my experience locally, but still some hospitals won't or can't provide it. But if you have access to those 2 tests, they're extremely important. The equally important, I think, is your CRP, your C-reactive protein. Patients with osteoarthritis will tend not to have an elevated CRP unless they have the so-called inflammatory osteoarthritis or the erosive osteoarthritis. But if you've got a patient with, again, symmetrical joint pain, early morning stiffness, elevated CRP, positive rheumatoid factor, and then certainly positive CCP, then you're talking about a rheumatoid arthritis. And that's the easy diagnosis, the label, if you like. The ones that may make the diagnosis difficult would be the patient who has the rheumatoid factor negative, or they can't have access to the anti-CCP, or their CRP might only be slightly elevated, 15, 20, and you're not sure where you're going. Go back to the history. If it's a new presentation, if they're talking about primarily early morning stiffness, it's an inflammatory arthritis until proven otherwise. The old diagnostic criteria included the use of x-rays and things like that, but they're not really of much use in the acute setting, and they're probably a waste of time. They're probably distracting. They're probably going to lead to a delay in proper treatment, so I don't think x-rays are useful. If one has access to a rheumatologist or a GP colleague who does ultrasound of joints, there are not many available, but if you do have access, then ultrasound can be extremely helpful. Certainly in our local hospital we have access to 2 excellent musculoskeletal radiologists who have excellent expertise on musculoskeletal radiology. They're looking for increased vascularity in the synovium on ultrasound, and that's a very useful test. If that's there, again, active inflammatory arthritis, let's get going. I don't think we need to use MRI in the early stages of diagnosis. It's got some excellent features, sure, but it's expensive. It can be difficult to access the patient, and again, it leads to a delay in the treatment of the patient, which is key, really. The patient needs early treatment.